Hello and a very warm welcome to everyone around the world who's joining the second session of our fourth series, which is the topic on indolent lymphoma. So I'm Kim Linton from the UK, and once again, very, very delighted to be joined by my co-chair and colleague, Astrid Pawlowski from Buenos Aires. So we've once again got an absolute star lineup of talks for you today. But before I introduce our speakers and our topics, I'd like to once again thank all of you for joining us today and make a small announcement, which I'm really very proud of. And that is that we've now got over 500 Women in Lymphoma membership globally, which is a huge achievement. We've got over 1,200 Twitter followers. And I'd like to really encourage all of you to advertise Women in Lymphoma to your organization and invite other fellow colleagues to join the organization. And we're not just clinicians, but radiographers, nurses, pharmacists, physician associates. We really are trying to diversify our membership because our power is very much in our numbers and our diversity. So please do advertise widely. I'd also like to very much thank the Snow Dome Foundation and Anna Steiner in particular for her organization of all of this, the steering committee for helping us to put together the Stellar program, and to all of our members around the globe for your commitment to these series. I'd also like to thank our sponsors. So this is Janssen in Australia, BMS and WiLing. Without your support, this wouldn't really be possible. So the format today is very much as it has been and will be for the remainder of the series, which is 2 talks with questioning in the middle. So we've got a panelist put together, which is our steering committee members, and the members of the audience. Please do put your questions in the question box. We very, very much would like to hear from you, and we'll try and address as many of those questions as we can in the session. So we'll all have our cameras and audios muted during the presentations. Please will the panelists put their videos back on when the Q&A starts. And so now it gives me enormous pleasure to introduce our first speaker, who I feel really needs very little introduction. Carla Casulo is very well known to many of you around the world for her pioneering work in the risk stratification of follicular lymphoma and innumerable publications relating to that. But she is also our very own Women in Lymphoma secretary. So Carla is an academic researcher at the Wilmot Institute, and she has a program of research, as I've alluded to, that's developing high-risk follicular lymphoma and stratified medicine, personalized medicine approaches. She's also program director for hematology and oncology and assistant director of mentoring and career development at the Wilmer Cancer Institute. So very much in line with what our ambitions are in Women in Lymphoma. So without further ado, I'd really like to introduce Carla, who's going to be talking to us today on risk stratification. So Carla, over to you.
Hi, good morning, and thank you so much, Drs. Linton and Pawlowski, for that wonderful introduction. It's very kind. I'm actually really honored and happy to be here to discuss this topic. It's a topic that I think is becoming increasingly complex and very nuanced, and something that I spend a lot of time thinking about. So this slide just shows sort of where I'm situated right here. I'm actually behind this hallway here. This is the Wilmot Cancer Institute situated in Rochester, New York, which is in the northwestern part of New York State. All right, so here are my disclosures. Okay, so first, why do we need to discuss risk stratification in follicular lymphoma? Well, because while it's very well known that the vast majority of patients with follicular lymphoma do very, very well, and survival has increased drastically over the last several decades, with responses to frontline therapy exceeding 90% and almost 80% of patients remaining alive at 10 years, most patients with follicular lymphoma will ultimately still die of their disease. And this was recently shown in a pooled analysis led by Clementine Sarkozy and colleagues, where the cumulative incidence of lymphoma-related death was about 10% at 10 years, and that's largely due to relapsed refractory disease requiring multiple lines of therapy or histologic transformation. So in response to this unmet need, a global effort is underway to not only define high-risk follicular lymphoma, but also try to impact on patients who are most vulnerable to early premature death. Several investigators for a long time now have captured the notion of high-risk follicular lymphoma based on unacceptably poor outcomes after treatment. And this has been described in a number of ways. For instance, decreased survival following lines of therapy. And this was demonstrated from Memorial Sloan Kettering, where over 1,000 patients with follicular lymphoma had reduced survival after second and subsequent lines of therapy, shown by this slide. And this called attention to a population of patients that really had a high risk of poor outcomes. Our study from the National Lymphocare study several years ago now showed that patients who were treated with chemoimmunotherapy with R-CHOP, who had early disease progression, or POD24, defined as an event within the first 24 months of their diagnosis and treatment, patients in that category had poor survival compared to a reference group of patients without early disease progression. And then in terms of outcomes following histologic transformation, this pivotal study from the University of Iowa and Mayo Clinic also demonstrated that patients had an inferior overall survival if histologic transformation occurred early, within 18 months of their diagnosis. So this whole collective population essentially defines a high risk of patients who are at risk of premature death from follicular lymphoma. And this creates multiple opportunities to discover biomarkers that could help patients at the time of their diagnosis and throughout their therapy to try to reverse some of this trajectory. But one of the challenges is that prognostic markers in follicular lymphoma occur not just at one specific time point. They actually occur on a continuum from not only diagnosis, but up until the end of therapy and beyond. So this really affects the practical implementation of prognostic markers. And it really leads to investigators being highly creative to try to exploit some of these vulnerabilities and affect our decision-making. So I'm going to try to, as quickly as I can, go through each one of these in more detail over the course of this talk. So we'll begin with some of the clinical prognostic markers that are extremely well defined. So the FLIPI and the FLIPI-2, we all know, are extremely well-regarded, well-recognized prognostic tools in follicular lymphoma that predict overall and progression-free survival. And the original FLIPI was based on a cohort of patients that were actually treated with chemotherapy only and very limited exposure to rituximab and FLIPI-2. And in particular, FLIPI-2 included 2/3 of patients that were treated with rituximab. But historically, this has shown inconsistent superiority in validation cohorts. So while very strongly used and consistently used, it does have some limitations. The PRIMA PI came along subsequently as a more simplified prognostic score that was built only on the use of beta-2 microglobulin and bone marrow involvement. And most patients in this group were treated with chemoimmunotherapy. It was based on the PRIMA study. And then in an effort to build upon that, patients and include patients that were treated with obinutuzumab containing regimens, the FLEX calculator came along that used patients treated on the gallium study. And this is the only prognostic tool currently that evaluates patients in the bendamustine era and is meant to predict both progression-free overall survival and POD24. So all of these collectively are highly efficacious and very important in terms of helping us predict outcomes, but it again misses some of the practical impact of using these tools to treat patients differently. So in addition to predicting both overall and progression-free survival, several of the FLIPI components, either independently or collectively, have also been found to predict histologic transformation. And this is especially the case when you combine grade, poor performance status, increased LDH, et cetera. And transformation, unfortunately, continues to be a very powerful driving force of poor outcome in follicular lymphoma. And while this risk may be dampened in the rituximab era, it continues to account for over 50% or almost 50% of lymphoma-related deaths. And this is also shown here by Sarkozy and colleagues, where the 10-year incidence of mortality after histologic transformation was about 46%. So while, again, clinical factors help to describe this high-risk phenotype, ultimately it's the follicular lymphoma biology that drives the protumoral state and affects multiple different mechanisms within follicular lymphoma and allows for a permissive environment. And a lot of this is driven by tumor microenvironment components and also epigenetic derangement. So I'll talk about that a little bit. So we heard from Dr. Oakson last week that follicular lymphoma cells live immersed within this rich microenvironment surrounded by immune components and non-malignant cells like the follicular dendritic cell and the T follicular helper cell. And these exert bidirectional influences on the follicular lymphoma and then back on the tumor microenvironment. This contribution to patient outcome was actually first established many, many years ago by Sandeep Dav and colleagues, who determined that high expression of genes from follicular lymphoma tumor-associated macrophages was associated with poor outcomes. And this is shown here, with immune response 2 being associated with poor outcomes. As time went on, more contemporary studies that incorporated rituximab demonstrated that this was a little bit more conflicting. And there was work recently published by Kreidel and colleagues that showed that high numbers of CD163 positive macrophages were actually independent predictors of longer instead of shorter survival, but this was only the case in patients treated with R-CHOP. So this underscores how therapy actually does impact on some of these prognostic models and can affect the heterogeneity of follicular lymphoma and the prognostication in particular of this particular tool. Subsequent work has demonstrated that not only the tumor microenvironment, but also the intratumoral immune infiltration is an important component of outcome in follicular lymphoma. And this was shown in a study from Princess Alexandria Hospital, where they evaluated whether the immune profile of follicular lymphoma was associated with early disease progression. So here they showed that immune molecules from either T cells, macrophages, or immune checkpoints clustered into either high expression, which is in the red, or low expression in green. And they identified that low levels of immune markers, so the green, was better at identifying patients that were enriched for early progression events. And this was then validated in an independent cohort of patients from BC Cancer and the German Low-Grade Lymphoma Study Group, and showed that patients had tumor infiltration low, had a higher proportion of POD24 events. So immune infiltration low tumors had high numbers of POD24 events. And again, this was something that was an additional mechanism to identify patients using different tools, different validation tools. Subsequently, NGS studies found that, next generation sequencing studies found that other epigenetic mechanisms are very frequently mutated in follicular lymphoma, and in fact are early events in follicular lymphoma tumorigenesis. So for example, the gain of function mutation EZH2 is found in about a quarter of patients with follicular lymphoma. And it's supposed to support immune evasion by suppressing cell cycle checkpoints and altering the follicular lymphoma microenvironment. So multiple investigators have identified that EZH2 mutations have actually a favorable association with outcome and are associated with favorable progression-free survival. But recently there was an exception to this that was noted in patients that were treated on the gallium study. So again, demonstrating that therapy does somehow impact on some of these prognostic models. And it showed actually that the hazard ratio for EZH2 became unfavorable in patients that were treated with obinutuzumab and bendamustine, and this is shown here. Additionally, there is an increased number of genomic alterations that have also been associated with early disease-related events. And this was a study that was, it was an American SWOG study, so the Southwest Oncology Group. It was a pivotal study published by Press et al. Many years ago now, comparing R-CHOP versus CHOP with radioimmunotherapy. And in a subset analysis of this study, they identified that, as one might expect, complex cytogenetics and a high mutational burden was associated with poor outcomes. In particular, gain of chromosome 2p and also loss of heterozygosity were associated with early progression of disease, and deletion of 17p was especially associated with poor outcomes as well. So TP53 alterations actually specifically occur relatively rarely in follicular lymphoma, only about 5% of the time, but they also have been associated with inferior outcomes and also early disease-related events, in particular early transformation. And this is an analysis that came out of the University of Rochester, my colleague Richard Burak, which demonstrated that when you evaluate TP53 mutations on a subclonal level, you actually have the ability of identifying a significantly high proportion of cases. And so here he demonstrated that when you look at subclonal TP53 alterations, it does actually differentiate survival of patients who were treated with radioimmunotherapy. So this is just a view into the fact that depending on the mechanism of how some of these mutations are evaluated, it may have a differential impact on some therapies, and that's something that might lead to future risk-adapted approaches to treatment. Other gene expression studies have also been associated with inferior outcome in follicular lymphoma. So Hewitt and colleagues performed a couple of years ago now, a large-scale gene expression profiling study from the PRIMA study. And they sought to define signatures that were correlated with adverse progression-free survival. And they defined a model based on 23 genes, essentially the expression of these 23 genes that were involved. They were actually pathways involved with B-cell centroblasts. And these were prognostic independent of the FLIPI score. And in a multivariate analysis, they identified that the 23 gene score had a PFS. If you had a low risk gene expression score, you had a higher PFS of 73% compared to 26% if you had a high risk gene expression score. And this ended up being a very robust model. It was confirmed in 3 independent cohorts. And then in a subsequent analysis by Princess Margaret Cancer Center, a modified version of this score was also found to have to be highly prognostic, particularly when you correlated it with FOXP1, which is a transcription factor. So again, suggesting that when you add some of the biomarkers along with some of the clinical factors, you might be able to augment the prognostic utility of some of these pathways in predicting outcome for follicular lymphoma. This here, the M7 FLIPI, is a clinical pathologic model that was developed a couple of years ago now that also tries to incorporate both the clinical and the genetics. So they looked at the mutational status of 7 different genes, as well as clinical factors based on patients from the German low-grade lymphoma study group and BC Cancer. And these patients were all treated with our chemotherapy. And the idea here is that the M7 FLIPI score, this combined model, this integrative model, was much more effective at risk stratifying patients, because here, as you can see, this is the standard FLIPI, and this is the standard, these are patients with high risk FLIPI in the standardly defined. These are low risk or non-high risk patients in the standard FLIPI. And you can see here that a significant proportion of patients with high risk standard FLIPI were reclassified as low risk M7 FLIPI. And that's important because patients that had the low risk M7 FLIPI actually did just as well as patients with the low risk FLIPI. So it sort of assumes or suggests that maybe we are overestimating the number of high risk patients by using just clinical methodology alone. So when this M7 FLIPI, which is really very, at the time and still is extremely revolutionary, and the first time a clinical pathologic model was using to define prognosis in follicular lymphoma, but when they looked at it in the gallium study, the M7 FLIPI actually, outperformed the FLIPI, still was not able to be prognostic of PFS in patients treated with obinutuzumab and bendamustine. And some of the thinking behind that is that perhaps this is driven by some of the EZH2 mutations that I spoke about earlier. So again, the prognostic model is highly contingent upon the therapy that the patient gets, because some of the treatment might abrogate some of these negative prognostic factors. So then the investigators that looked at FLIPI, so some of these investigators subsequently went on to see whether this could be used in particular to predict POD24 early disease progression. So Vindy Juranovic and colleagues, they further examined the M7 FLIPI, and they used the same patient cohort as before, and also similar mutational data, but only using 3 specific genes, EP300, FOXO1, and EZH2, so not the 7 genes, the full 7 gene spectrum from the M7 FLIPI. And then compared to the M7 FLIPI, this new model, which they call the POD24PI, it had greater sensitivity to predict POD24, but it didn't outperform other metrics. And this was largely because of lower specificity. So another model came along called the BioFLIPI, and similarly integrated the FLIPI with several other genes involved in the tumor microenvironment. And they also identified that there were several of these genes that were associated with early treatment failure, but only one thing, which was lack of intrafollicular CD4 positive cells, were predictive of treatment failure. So what I'm trying to demonstrate here is that despite this extremely broad plethora of information, we still are in the process of trying to be as nuanced as possible to identify how much can we select out from the heterogeneity of follicular lymphoma. So next we'll talk a little bit about functional imaging, and I'm not going to go into that too much because I know Dr. Barrington will discuss that in a lot more detail. And we'll also touch a little bit on circulating tumor DNA. and minimal residual disease. So we know that the use of PET for baseline disease assessment in follicular lymphoma is becoming increasingly more common and standardized. And a few years ago, a study by Magnan and colleagues pooled 3 European studies of patients with advanced stage of follicular lymphoma treated with chemoimmunotherapy. And they basically were looking at whether baseline PETs, where you could identify total metabolic tumor volume, again, that was defined as 510 centimeters cubed. So higher, they found that higher total metabolic tumor volume from the PETs in these pooled studies was associated with lower progression-free overall survival and also several high-risk features. So based on this, the total metabolic tumor volume has been combined with FLIPI2 and was able to identify 3 distinct cohorts of patients with varying outcomes. So here, low FLIPI2, low total metabolic tumor volume having the best outcomes, high FLIPI2 and high total metabolic tumor volume having worst outcomes. And again, I don't want to emphasize this too much because it's going to be discussed in greater detail by Dr. Barrington, but this aspect of imaging, functional imaging, either by itself or in combination with other biomarkers, is a very open field where a lot of people are making huge contributions to understanding prognosis in follicular lymphoma. Other studies have shown that baseline SUV max, either again independently or together with other markers such as Ki-67, could select patients that are at high risk of poor outcomes in follicular lymphoma. So this particular study actually did not appear, appear to predict histologic transformation in this particular analysis of the gallium study. And the authors analyzed cutoffs of baseline SUV max of greater than 10 and greater than 20. And they actually found that the histologic transformation risk was not only small, but that the median SUV max was actually similar between patients with transformation and without transformation. So I think there is more to come on the impact of baseline SUV max in follicular lymphoma. Here, let's talk a little bit about minimal residual disease and cell-free or circulating DNA. So lots of evidence is suggesting, and this is another growing area of interest of mine, lots of research is suggesting that the persistence of residual tumor cells within the bone marrow and in the peripheral blood of patients with follicular lymphoma is an independent predictor of relapse. And there's many ways to do this, actually. There is PCR-based assessments looking at the BCL2 immunoglobulin heavy chain. And then there's ways to look at cell-free DNA, which is actually not tumor specific, and then also looking at circulating tumor DNA. I'm just going to touch a little bit about the minimal residual disease based on PCR. So here, this was a study that looked at BCL2 IgH PCR in patients both before and after treatment in the peripheral blood. And they found that, as you might expect, there was an adverse impact of high pretreatment levels, high pretreatment BCL2 IgH levels on subsequent progression-free survival. And then this other French study demonstrated that when you looked at cell-free DNA only in combination with total metabolic tumor volume, and this is shown here, it enhanced the prognostic utility of just the total metabolic tumor volume alone. And they found that there was a significant correlation between having total metabolic tumor volume and the circulating tumor markers. So again, I think that this is a platform upon which more and more can be built. I wanted to just touch a little bit on one of a recent study that was presented at Lugano and is likely going to be published very soon, looking at adapting therapy based on the presence of minimal residual disease. And I think that that's a very intuitive approach. So this was a recent study that was done by Dr. Stefano Luminari. This is the Fall 12 study. And here what they decided to do is to try to verify whether there is a response, whether response adapted management in follicular lymphoma could be achieved based on response to therapy using either PET and or minimal residual disease that was done by BCL2 IgH PCR. So here I'm just going to walk you through the study a little bit. So they began with high tumor burden follicular lymphoma, and patients were treated with either R-CHOP or R-Benda. And then the reference arm, where patients were PET with some metabolic response, either CR or PR, went on to receive standard maintenance rituximab every 2 months for 2 years. And then the experimental arm used 3 different types of post-induction strategies. So patients that had complete metabolic response and were MRD negative ended up being observed. And patients who had complete metabolic response but were MRD positive went on to receive an abbreviated course of rituximab. patients that did not have a complete metabolic response went on to receive ibertumumab, Tioxetin, and then standard rituximab maintenance. And the primary endpoint was progression-free survival. So there were 712 patients that were included, and the follow-up was about 6 years or so. And what they found, interestingly, was that patients in the standard arm that just received the standard maintenance rituximab, they actually had a significantly better progression-free survival compared to those that were on the experimental arm. And again, the experimental arm was the one that risk stratified patients based to different types of maintenance based on their MRD status. So this was confirmed actually in all of the arms of the experimental arm, and there was no difference in overall survival. So even patients, when you look at just the population of patients that had a complete metabolic response and were MRD negative, even those patients who you would think would have the best outcome, even they did a little bit worse compared to patients that were in the standard arm. And this is actually somewhat surprising, but suggests that perhaps this particular approach wasn't the ideal mechanism to risk adapt. But what I like about this is that it's one of the first really bigger studies that looked at opportunities to intervene in patients based upon a predefined endpoint of risk. And I think that this is sort of what is coming in follicular lymphoma, and I think what's really exciting about risk adapting patients over time. So let's conclude by discussing early disease-related events and some of the prognostic markers that are evolving in this particular space. So we spoke earlier about capturing high-risk follicular lymphoma early in a disease course and focusing on patients that have poor subsequent outcomes. So we talked about POD24, but actually my colleague Matt Maurer out of the University of out of Mayo Clinic, in combination with colleagues at the University of Iowa, looked at an earlier time point, which is EFS 12. So this study looked at the impact of remaining event-free at 12 months from diagnosis. This particular group was very heterogeneously treated. Patients were treated with either observation, some got chemoimmunotherapy, some received rituximab only, chemotherapy only. But what they demonstrated was that the median overall survival for patients remaining event-free was similar to that of age-matched control. So this is the group of patients that did not have an event at 12 months. And these were patients that did have an event at 12 months. And this was confirmed in a validation cohort of patients from Lyon, France. So again, speaking to the fact that not just at 24 months, which happened to be the time that we selected in the Lymphocare study because it captured most of the patients with some early event, but any time along that continuum, failing to achieve event-free survival either at 12 months or at 24 months still remain a very robust metric of outcome, of poor subsequent outcome. A few years ago, we looked at patients that were enrolled on multiple clinical trials. This was something called a FLASH investigation, and this was recently published in Blood. So this looked at over 5,000 patients with follicular lymphoma treated on 13 clinical trials, multi-center international randomized studies, to determine whether the information that we observed previously persisted in a larger, more heterogeneously treated group of patients. And what we discovered was that the impact of POD24 was still impactful, was still observed, but when you actually make the group more heterogeneous and you mix immunotherapy with chemoimmunotherapy or chemotherapy alone, that poor impact of disease progression is slightly attenuated. And that's not surprising, because I think that patients that are the most vulnerable are those that are treated with the most aggressive approach in the beginning, so chemo plus immunotherapy, and patients that relapse even despite that earlier in their course are the ones that you'd expect to do worse. So what we did was trying to build upon this large group of patients and see if there was any clinical factors that were consistently prognostic, to see whether that could be a platform upon which to add additional things like functional imaging or other molecular biomarkers. And we identified male, gender, poor performance status, high-risk FLIPI, and increased beta-2 microglobulin were all associated with early progression. A lot of these have been identified in other cohorts and also associated with early transformation. So I think that some of these are very recurring and also they've essentially, I think, validated that these are very important factors in follicular lymphoma progression. There's a lot of data coming out to suggest that the POD24 impact is really driven by occult transformation. And I think that there's something to be said about that. So we know that this is a poor surrogate for survival, and we've already described it. It has some limitations. Some of the studies recently have shown that this is maybe impacted by the type of chemotherapy given. So this was a study that was published by Dr. Friedman from BC Cancer and showed that when patients are treated with bendamustine and rituximab and relapse within 2 years, actually a lot of them are enriched for early transformation. And this cohort, almost 75% of patients. In the PRIMA study, patients at first progression who transformed were only made up about 30% of patients. So I think the impact of transformation may depend upon what the patient gets for their first treatment. And I think that a lot of this is still an ongoing discussion. So we've come a long way looking at a very broad biologic landscape that has annotated multiple different influences. And I think that impacting patients ultimately is going to take ongoing improvement of some of these factors to really impact prognostic accuracy a little bit better, and also to, in my mind, define therapy selection. I think that's where our future direction should focus on. Is we've defined some of these risk factors, but how do we actually leverage them? And then how do we mitigate risk based on designing a precision approaches to therapy? And I think that has really the greatest potential to impact patient care. So I want to thank my colleagues at WIL. I want to thank the audience for being present. And I wanted to thank my family who supports my work. These are my 2 kiddos, and this is our pandemic puppy, Lola. They all make my work very worthwhile. And again, thank you very much for your attention.
Thank you so much, Carla, and thanks for grounding us with pictures of your family and your little dog at the end. Because I don't think many men in lymphoma would have ended their talk that way. So, congratulations on a fantastic achievement. You've really contributed so significantly to our understanding of high-risk follicular lymphoma, and that's very much a driving force behind all our clinical trial designs going forward. And as you said right at the end, we've come a long way, but actually there's a long way to go. And I'd just be interested in understanding a couple of things from you. The first is FLIPI and FLIPI2 and all of the other clinical-based factors have become very much integrated into the fabric of how we do things. We always record it, we always do it in clinical trials. Now, aside from the FLASH study and the M7 FLIPI, which didn't obviously validate in gallium, how important do you think the FLIPI and other clinical factors are going to be in our new prognostic models as we go forward? Or do you think that actually it's going to be replaced by the biological based factors and the monitoring with PET and ctDNA and other factors? We discussed and touched on this briefly last week with Jess, but I'd really be interested in your views on that.
I think until some of these molecular markers and some of these mutational tests become streamlined and available to people routinely, I can't see how the clinical pathologic models will surpass the clinical models. So I think it's really relevant to keep the FLIPI present and the FLIPI2 when possible, because they still are very tried and true mechanisms to define risk. But I think that at the end of the day, when I'm in my clinic with my patients, and in fact, I saw several patients with follicular lymphoma yesterday, and speaking to the fellow with me, we're still sort of, geez, this person has their FLIPI scores too, but what do we do differently with their treatment? At the end of the day, that's still really what the question that remains unanswered. So I think it's good to collect all the information, but I think we're really interested in trying to impact on our treatment in a more precision way is the way I would look at it. So I'm really optimistic about people like Jess and others trying to make these molecular tests accessible to the everyday physician, just like Foundation 1 is sometimes used for solid tumors to help define pathways that are aberrant. I think that we're overdue for that in lymphoma.
Absolutely. I think developing risk-adapted strategies at the very baseline is the way we're going to be going forward, isn't it? Thank you, Carla.
Thank you, Carla. And I want to echo Kim's words on thanking you for all your contribution in follicular lymphoma. And I also wonder, how do you see all of these prognostic scores in a relapse setting? Because we are very worried about patients when they relapse or when they have an early relapse, and now we have many different treatment options for a relapse setting. So what is the role of all of these prognostic factors when we need to decide on therapy at relapse?
That's a really good question. So that's actually something that it's an ongoing investigation. That's work that my colleagues and I are actively doing right now. And there's some data to suggest that the FLIPI and FLIPI2 remain really important, and actually they do change over time depending on the therapy, and some of it is consistently impactful and some of it is not. But I think that that's sort of the next wave of where we're going in follicular lymphoma, is trying to understand what is relevant at the time of recurrent disease. We can use FLIPI, we can use FLIPI2, but it may not matter. I think that remains to be seen, and more work on that is hopefully will be coming out soon, and is an area of ongoing investigation. But I think that you're absolutely right. That's really a pivotal question that a lot of people, including myself, have.
And maybe we will have to reassess the role of these prognostic factors in the era of new drugs.
Definitely, absolutely, because as we talked about earlier, that depending on what a patient gets, it might completely abrogate that negative risk, which is fantastic, but then that tool becomes inaccurate. So I think that that's really, really relevant.
You've asked what I was going to say, Astrid, which is, we're almost chasing a moving target here as the therapeutic landscape becomes more and more complicated, more biologicals come in. We haven't yet sorted out how our tools work with immunochemotherapy, let alone how it might work with novel agents. And I suppose you're right, Carla, in that we have to continually ask the same questions of our trials going forward. So we have an ability at least to try and work out the connections between our prognostic markers and our therapies going forward.
I agree.
So we have a question from Pam, from the participants, and she says it would be great to de-escalate therapy in patients who will have favorable long-term outcome. It is disappointing about the FOL12 trial that you just mentioned, that PET and MRD may not have been the right starting point. How do you think we can work on this, or what do you think we could use instead?
That's a really good question. So I think one of the limitations of that is that minimal residual disease can be captured in a myriad of ways. So PCR based is one strategy, but some investigators are looking at different sequencing methods like CAP-seq and other circulating tumor DNA, because the problem with the PCR approach is that not every patient has something that you can sequence. So you miss about 40% of people using that approach. So it's possible that it was a very adequate design, and I don't doubt that, but it's just that it didn't capture enough people. So maybe we just lost the signal had we been able to capture more patients if more of them had markers, because not everyone in that study had all of the markers in the beginning. So if we use circulating tumor DNA, that might be a way to abrogate that, because you can capture more patients. The other thing is that not everybody's getting bone marrow biopsies in follicular lymphoma. So, I think that that's a missed opportunity as well. And I think that we just have to find a better way to identify the patients in the beginning and then track them over time. But I would love to de-escalate therapy, and I would love to limit the duration of therapy, because I know that in the US, some physicians in the US, myself included, use maintenance on a much more sporadic basis. I know that in Europe and in other parts of the world, it's used much more often. So that would be a perfect opportunity to investigate this prospectively. So I love that idea about de-escalating therapy.
So look out for the results of the Petrea clinical trial, which is obviously ongoing and has a long time to report, but that may shed some more light on PET-adapted therapy, and particularly PET-adapted maintenance in follicular lymphoma. Carla, thank you so much again for your fantastic talk. I think given the time, we probably ought to give Sally a chance. So
definitely, I want to hear Sally's talk.
So thank you once again. And now it gives me enormous pleasure to introduce Sally Barrington, who's a professor of PET imaging at the UK National Institute for Health and Research. And she's really best known for developing and implementing the international guidelines by which we now classify and response assess our patients with lymphoma, not just the ones with follicular lymphoma. She's the one who's developed the 5-point Deauville scale, and we thank you enormously for that, Sally, because you've made great strides in how we do things. You are the lead for the UK PET Core Imaging Centre, and you lead a very strong program of research that's continuing to push the PET boundaries. You really don't need much of an introduction, Sally, because I think you are globally well known, and we are so honored to have both you and Carla here to speak to us today. So I'll hand over to you to talk to us about the utility of PET in follicular lymphoma.
Thank you very much, Kim, for that lovely introduction. And it's really nice to be here, and it's really nice to be invited to give this talk. And I'm very pleased to be sharing the platform with Carla Casulo. So I think we know that the role of PET-CT is very firmly established in aggressive lymphomas, but really its utility in follicular lymphoma has been much more recently explored. And probably one of the first studies to look at the role of PET, certainly at staging, was a PET sub-study in the FOLLO-5. And this was 142 patients who were treated with immunochemotherapy, and PET-CT was compared with conventional staging. And clearly PET-CT detected more nodal and extranodal sites, and it changed the FLIPI score in a percentage, and it changed the Ann Arbor score in a percentage, because there were extranodal sites that weren't detected on CT, in particular in the bone, the liver, and the gut. However, the PET missed bone marrow involvement in 43% of patients without bone lesions on PET, and therefore this really had rather limited implications for the management of patients with advanced stage disease. However, in limited stage, apparently on CT, PET actually upstaged nearly 2/3 of patients. And that, of course, has implications for the management of these patients with radiotherapy. And my colleague, Jess Brady, performed a retrospective study looking at 512 patients who had been staged as having stage 1 or 2 by PET at various international centers. The majority of them had stage 1 disease, and reported that these patients had really very good outcomes, with a 5-year freedom from progression of approaching 70% and a 5-year overall survival of 96%, with a very low in-field relapse or marginal recurrences, suggesting that there is indeed a curative potential for radiotherapy in these patients. In her study, the other, apart from stage, the other independent predictor of freedom from progression was BCL2 status. And combining these two, you can see that patients in, this is if you look in panel C, you can see that patients that had stage 2 disease but were BCL2 negative had similar outcomes to patients with stage 1 disease. At a similar time, another study reported a comparison between radiotherapy and systemic treatment. Towards the end of the course of this very long study, rituximab was added to CVP, and there was a survival advantage for patients who were treated with RCVP and radiotherapy compared to those who just received radiotherapy. But it's important to note in this study that only about half of the patients had been staged by PET, and that the PET staging was associated with superior progression-free survival compared to those that were staged by CT, again pointing to the accuracy of PET in this setting and its important role in selecting patients for radiotherapy. So then moving on to PET and histological high-grade transformation. There were a number of early reports, such as those from Caroline Baudet-Milin, that in selected populations with clinical concern about histological transformation, FDG uptake was reported to be higher in aggressive than indolent lymphomas, and has been used to target biopsy sites for biopsy in suspected transformation in follicular lymphoma. However, I did put in here the gallium study design, but I'm sure it's well known to all of the people probably on this call. We didn't, as Carla mentioned, this wasn't actually found in the gallium study. There was in fact a very low rate of transformation of only 2.7% of patients, and neither the median maximum SUV nor the range, which is the difference between the uptake in the hottest lesion and the lesion that had the lowest uptake. You would expect that if you had patients who had transformation, you might see some very hot areas. So you would expect that the range would be much wider. This was not associated with transformation. And therefore, there seems to be little benefit in rebiopsy to exclude transformation based on SUV alone before initiating therapy in high tumor burden follicular lymphoma. And this has certainly changed what we do, because I think it was our habit to rebiopsy if we were concerned. This actually has a slightly different take on PET and high-grade histological transformation. This is a study from Connie Bat-Levy and colleagues, where they looked retrospectively at 346 patients from the Memorial Sloan Kettering, which was their discovery set, and then they validated it in 484 patients from the Follow-5 study, all treated with immunochemotherapy. And they found that the rates of early progression were higher in patients who'd been staged by CT than PET, and that although the earlier progressors had inferior overall survival when staged by either technique, the effect was much more marked in those staged by CT. And they found that the risk of transformation was higher in earlier progressors staged by CT than by PET. And so they questioned whether maybe this was because PET identified more patients at diagnosis with transformation, and that therefore these patients weren't misdiagnosed and treated with immunochemotherapy. Interestingly, though, the overall rates of transformation were very low and were similar to gallium at around 4%, suggesting that the improvement in outcomes in patients staged by PET over time may be multifactorial, including much more effective combination immunochemotherapy over time, and perhaps other factors that I will discuss. Now, Carla's already sort of talked about this, that the metabolic tumor volume perhaps provides us with a little bit more of a sophisticated measurement of tumor burden than making a simple sort of single unidimensional measurement of the largest lymph node. And she's also mentioned this study by Michel Mignon and colleagues that showed that the metabolic tumor volume was prognostic for both progression-free and overall survival. But I'll draw your attention to the fact that 82% of these patients were treated with R-CHOP, and that only a quarter of patients received maintenance therapy. And this was just to show you that in multivariable analysis, the only independent predictor of both progression-free and overall survival was MTV. In the gallium study, however, we looked at 521 patients and found that there was no association of metabolic tumor volume with progression-free survival, which we were a bit disappointed and a little bit surprised about. But bear in mind that the majority of these patients were treated with bendamustine, and that all of the patients received either obinutuzumab or rituximab as maintenance therapy. And what's interesting is a new study that has been published, which I'll talk about, by Nath and colleagues. And as has been mentioned by Carla, obviously the tumor microenvironment and the tumor infiltrating lymphocytes are an important factor in the behavior of follicular lymphoma. And what this group did in Australia was that they analyzed follicular lymphoma biopsy samples and looked at the population of B and T cells in the tumor and the tumor microenvironment using various techniques. And they correlated this with the maximum SUV in the lesions and the total metabolic tumor volume. And what they found was that CD8 cytotoxic T cells and the CD4 T cells, in particular the T follicular helper cells, had significantly higher glucose uptake than the B cells. But because B cells dominated, it was actually the B cells that were the drivers for the total metabolic tumor volume. And indeed, that the T cell population was inversely associated with metabolic tumor volume, and that the T follicular helper cells and the CD8 positive cytotoxic T cells were in fact clonally expanded in low MTV states, meaning that maybe the intratumoral T cells are influencing the ability of MTV to predict outcomes. And perhaps because treatment regimens vary in their ability to induce T cell depletion, perhaps this explains the apparent inconsistency in results between gallium and the pooled analysis. So, oh, sorry, I skipped over quite rapidly there. The other thing I just wanted to mention was about baseline SUV max in this study. And they found that high SUV lesional values were associated with CD4 and CD8A gene expression, but not CD19 expression. And there was a trend towards a positive correlation between the CD4 positive cellular glucose uptake and the SUV lesional uptake. So maybe this influences the ability of SUV max to predict both tumor grade, which was talked about by Carla, about the fact that it didn't necessarily always predict tumor grade, and its ability to predict histological transformation. So moving on then very rapidly to remission assessment, and clearly Judith Trotman has done a lot of work in this area. The first pooled retrospective analysis from these 3 studies looking at PET within 3 months of the last dose of induction immunochemotherapy, which where the PET was reviewed by 3 nuclear medicine physicians using the 5-point scale that's also known as the Deauville criteria after it was adopted as the preferred method for assessment using PET in lymphoma, showed that there was a clear progression-free and overall survival advantage for patients that had a complete metabolic response defined in this study by the best cutoff of 1, 2, or 3 for complete metabolic response and 4 or 5 for non-response. And then this was prospectively assessed in gallium. Judith managed to persuade investigators that there should be a PET sub-study funded, and the scans were reviewed by an independent review committee using CT response and PET CT response with 2 criteria, the now outdated International Harmonization Project criteria and the Lugano classification, which included Deauville, which incorporated Deauville, I should say. And what was the reason to move towards the sort of Deauville classification? Well, it was because there was a better inter-observer agreement using the liver, which was the score 3 than score 2, and an improved positive predictive value compared with the IHP criteria in other lymphoma subtypes. And these are the results showing the remission assessment by CT in panel A, by PET CT using the IHP criteria in panel B, and the Lugano criteria incorporating the Deauville 5-point scale in C. And you can see that the best discrimination was using the Lugano criteria. And this was also predictive of overall survival. And indeed, the PET status was the only independent predictor of both progression-free and overall survival in this study. Just a word about the impact of bone marrow biopsy on response assessment in gallium. This was a study published by Sarah Rutherford. And although we know that bone marrow biopsy clearly isn't bone marrow involvement isn't well imaged using PET, it was interesting that in this study, there were only 10 patients with complete metabolic response, whereby the bone marrow biopsy was at variance, with 5 with positive and 5 indeterminate results. And of the 5 with a positive bone marrow biopsy who had a complete metabolic response, 1 had progressive disease, but the others all had maintained response at more than 5 years of follow-up, suggesting that bone marrow biopsy in this case added little to response assessment in follicular lymphoma. And therefore it may be reasonable to defer the bone marrow biopsy in advanced stage follicular lymphoma, where the therapeutic intent is to watch and wait, or where the bone marrow biopsy won't impact on the therapeutic approach. So then a quick word about response adapted treatments. I don't really need to go through this because I'm very grateful to Carla for already explaining it better than I would have done. And the results that have been described, and suggesting that this particular management strategy in the FOL12 probably wasn't the best, but that the future development of response-adapted therapies is still possible. And Kim has just mentioned to you about our study, which is being conducted at the moment in UK and Australia, called the Portrea study. And in this study, patients who have immunochemotherapy for high tumor burden follicular lymphoma have a PET-CT scan at the end of induction treatment. Those with a positive scan are randomized either to stop treatment or to continue with maintenance treatment. And we've just had an amendment approved that will allow us to use obinutuzumab or rituximab. Whilst patients who have a PET positive scan with a Dover score of 4 or 5 are randomized either to continue with the antibody alone or to continue with the antibody and lenalidomide. So to sum up then, I think in terms of the utility of PET in follicular lymphoma, clearly PET is more accurate than CT for staging and particularly important in the assessment of patients with apparently limited stage on CT for treatment planning. I think it's also important in the era of PET response assessment that we need a baseline PET scan. Limited stage patients have good outcomes with radiotherapy. It seems that leading on seamlessly almost from Carla's talk, that the predictive ability of baseline PET parameters is affected by the tumor microenvironment and possibly by those tumor infiltrating lymphocytes. I think we all agree that the PET-CT is now the gold standard for response assessment at end of induction therapy. PET-guided therapy is now beginning to be tested in clinical trials, and that PET response may be a useful surrogate for progression-free and overall survival in future response-adapted trials. And with that, I'm just going to thank you all very much for listening, and it's great to be here this afternoon.
Thanks very much for that, Sally. And it's wonderful to see that you had photographs of all the leading women on your slides, crediting them for the work that they've done. So thank you for doing that. I think you've made a good case for the utility of PET in early stage disease because it's prognostic and it guides therapy. And you've explained that you need to do baseline PET in advanced stage disease because you need that to obviously have a baseline assessment in terms of the reference for response, measuring your response at the end of induction. I guess the utility of PET for identifying areas to biopsy for high-grade transformation remains an area of uncertainty, and the utility of MTV in relation to the treatment that you receive is also an evolving question. I want to just come back to the transformation thing because it's the biggest concern that we have as clinicians is trying to work out who's at risk. And we do still in our MDT meetings see areas of FDG uptake that are relatively discordant on the baseline scan. So you might see areas that are hotter than others. Do you suggest we biopsy those areas, or are we wasting our time?
So before the gallium study, that's what we used to do. We always used to biopsy them. Now, I think, to be honest, you're probably wasting your time. I mean, if you look at the 2.7% of patients transformed, I mean, you could argue that, perhaps those patients have already been pre-selected before they got entered into gallium. I suspect not, given how difficult it was to actually get PET scans done in gallium. I mean, it was mandatory to begin with and then became optional. And if you look at Connie Bat-Levy's data, that stretches back over a number of years. And again, the rate of transformation was really low. So I think, to be honest, if you're happy, you've got a good sample, I'm not sure it's fair to sort of subject patients to another biopsy and, of course, to delay starting their treatment.
Thanks, Sally. That's really clear.
But maybe other people have different thoughts.
Thank you, Sally, for such an excellent lecture. And you mentioned in your last slide about future clinical trials on PET-adapted therapy. Is there a role for interim PET in follicular lymphoma?
So I suspect not so much, Astrid. I have to say that interim is not as predictive as the end of induction PET scan that's been looked at in a number of trials. And I guess at the moment, I mean, when is the time to intervene? And my impression is that you haven't got a lot of options to intervene at interim. So I think people are really concentrating on the end of induction.
Mm-hmm.
So Sally, we've got a question that Carla's posed, and that is, what do you think is the next best biomarker to add to PET for prognosis?
Oh, Carla, that's hard. You need to come on camera now. I don't know. Are you talking about imaging, or are you talking about non-imaging? Because I think that's your area, and I think you might like to answer this question.
No, I'm talking about imaging. Anything
Oh,
else?
okay. So at the moment, not in, well, so there's a lot of discussion in Hodgkin's and diffuse large B-cell lymphoma about the maximum distance between lesions, sort of reflecting disease dissemination. I don't know whether that would be so important in follicular lymphoma. I'm not really aware of anything at the moment, Carla, other than MTV. But I mean, there's all sorts of options in terms of radiomics. I think follicular lymphoma is quite a difficult disease, don't you think? Mm-hmm. Because I mean, I was really interested listening to your talk and about how all these predictive and prognostic factors are so influenced by the treatment regimen. So I think it's tough. And I certainly would like to drill down a bit more, because I didn't present the data, but one of the things we struggled with in the gallium study was that actually there was a, in the patients that were treated with CHOP chemotherapy with whichever antibody, there was actually a significant difference in the predictive value for MTV. So I think we need to drill down a little bit more into this.
We have another. Oops, I'm sorry. Go ahead.
No. I was just going to say to Kim, perhaps there's an opportunity in Petraea to look at this.
There potentially is, actually, Sally. I was just going to say we should chat offline.
Sorry, Astrid.
You can chat now, and we can all listen to your suggestions.
I think we've got a question from Guinevere.
Okay. Yes, the question is, off trial, how are you using end of induction PET information to guide treatment, to guide therapy at present? Rituximab maintenance versus none in frontline?
I'm not sure.
Question for Sally to answer as a non-clinician.
Well, I was going to, yeah, I think probably Kim is probably better to give the answer to this. I mean, my impression is that before the pandemic, I think people were probably giving rituximab maintenance therapy, and I'll let you now talk about the nuances since the pandemic, Kim.
Yeah, I mean, it's a difficult one. I think the bottom line is in our centre that we're not using end of induction PET to guide maintenance decisions outside of a clinical trial. So we are offering maintenance rituximab to individuals whom we feel are the right fit in terms of their age and comorbidities to tolerate maintenance rituximab. And that threshold has increased with the pandemic. So we're less likely now to offer maintenance rituximab if the person is a little bit borderline in terms of their fitness because of the risk of complications. And I do want to reinforce that I think it is wrong for us to assume that somebody who achieves a complete metabolic remission doesn't need maintenance rituximab. That remains an open question. So certainly I would caution people not to use the PET at this time until those data come through. So I just wanted to ask you one more question, Sally, and that is the role of PET in patients prior to undergoing stem cell transplant. Do you think that we should be using that to guide our decision-making as to whether we do or don't transplant people?
Well, as you know, Kim, there's very little data. We have just recently done Toby Eyre and Will Townsend, my colleagues in the UK, have recently done a retrospective analysis that suggests we should, but watch this space.
So that too remains an open question.
It does.
So apologies, there was a late question coming through to Carla, which I might just ask Astrid to raise before we then move on to the closing session.
Yes, I think we have a couple of questions. One is referring to pot 24. How is that calculated in a PFS curve? Do you start after 24 months or is it done differently? When do you start counting 24 months? I think that is the question.
So the original definition was based on patients that were diagnosed and treated shortly after diagnosis. So you can actually, they're somewhat interchangeable, at least in the original LymphoCare study definition. And in FLASH, it was for patients that were from the time of their enrollment onto the clinical trial, not necessarily from diagnosis. So the vast majority of patients that we looked at was from diagnosis, with the caveat that our inclusion criteria was that they had to have been treated within 6 months. So and then Matt Maurer looked at patients who it was from the time of their diagnosis. So I think that traditionally you should use the time of diagnosis, given that the majority of patients will be treated when they're diagnosed. And even if they're not, an early event will still be impactful. I hope that helps answer that question, but that's the way we calculated it.
And we are short of time, but we don't want to leave any questions outside. So there's another question, and it's regarding circulating tumor DNA. Is there any indication as to the time frame of needed to get samples from patient to monitor this? How early can we pick this up?
Well, I think that there's less data in follicular lymphoma. There's more in large cell looking at this. But I think that it's at the time of their diagnosis and probably at any time point over therapy that you would want to capture and correlate that to some clinical endpoint. So absolutely at the time of diagnosis, absolutely at the time of disease recurrence. But the frequency of that really is an area of ongoing research, and there's no set timeline to say it should be done here or it should be done there.
Okay, I think we could go on talking, but we're already over our time. So I really want to thank Carla and Sally for these excellent lectures. I think we all learned a lot and we will keep on learning from you. So thank you very much. Thank you,
Kim, for the invitation.
Thank you, Kim, for co-chairing this. And I want to also thank all the WIL community, this growing community and the steering community. I want to thank Anna Steiner for her hard work, helping us get everything together and the Snowdown Foundation, and also the sponsors for this session, the Barrington, Bristol Myers Squibb, Janssen Australia. And we will see you next week, where Kim and I will try to do our best to try to update treatment of first line and relapse setting. Thank you very much.
Thank you.
We look forward to it. Bye-bye.
Bye.
Thank you all very much. Bye-bye.
Thank you. That was fantastic. Bye-bye.